I'm going to introduce myself. I'm Shivani Gupta, and I'm one of the faculty members here in ophthalmology in the division of oculoplastics, so treating patients who have thyroid eye disease. There are 6 other colleagues, 3 of whom will also be speaking at this session today. As a whole, we work with our other colleagues within the eye center and outside the eye center to manage patients with thyroid eye disease. I want to thank you all for coming. I know, you braved the weather, the ice that I almost fell 3 times walking just from the parking lot here. So the conditions are not great, and it's, I think, the last of the Michigan game day. So there's a lot to tackle in getting here. So I appreciate you making the effort. Exactly, no pun intended. I appreciate you making the effort to get up and make it here today. One of the benefits of coming is having the chance to ask questions that sometimes when you're in the appointment and there's so many things getting thrown at you, you don't really have the time to sit there and digest, and you've forgotten the questions you came in with, and then you leave and you might be a little confused and you think of these questions and you go online and get more questions. So this is a forum for you to be able to ask those questions and also to hear about some things that perhaps you're not aware of. If you haven't been seen at the University of Michigan, you're all welcome to call and make an appointment. We hope to host more of these workshops in the future, so for those of you who didn't get an opportunity to hear the thyroid talks, there may be that opportunity in the future. So I wanted to talk about what is thyroid disease, and someone had brought up a question, well, I also have Graves' disease, and that's being treated too, and how is that different from thyroid eye disease? Do I have both? So taking it a step back, most patients who have thyroid eye disease, the majority, overwhelming majority, also have an underlying thyroid disorder. Most commonly, it's an overactive thyroid or hyperthyroidism. And in most cases, that's an autoimmune form of hyperthyroidism called Graves' disease. So Graves' disease most commonly affects your thyroid gland. For some reason, your body produces antibodies that react towards cells on your thyroid gland. But also, and we're still trying to understand why, patients who have the thyroid disorder can also have inflammation targeting their tissues around their eye, which is called thyroid eye disease, and also they may have some skin changes, pretibial myxedema, you may have heard of that, affecting the lower legs. So Graves' disease, when it affects the thyroid, affects your whole body, right? Because the thyroid produces hormones that control a number of different things like metabolism and such. So you may have systemic effects from the Graves' disease that is coming from the changes in your thyroid, but also about 50% of people who have Graves' disease have some form of the eye disease. It may be mild, it may be moderate, it may be severe, but about half of those people will show some eye changes. Now, what is thyroid eye disease? So it's an autoimmune inflammation of the orbit and the soft tissues around the eye. As I mentioned, it's most of the time it's associated with underlying thyroid disease, and in most cases that's Graves' hyperthyroidism. But rarely we do see patients who have hypothyroidism who present with some eye disease, people who have Hashimoto's thyroiditis, and then also some patients who have normal thyroid function will come in with changes around the eye. So all those can be seen with thyroid eye disease. But really, most commonly, it's people who have Graves' hyperthyroidism that we see. In terms of the time course, and this may or may not apply to you, most of the time, the eye symptoms or the changes in your eye start within 18 months of your thyroid diagnosis. So your eyes might have started changing a little bit before you ever knew you had thyroid disease. They all might happen at the same time, or sometimes it's after. About 80% of people will have those changes within 18 months of finding out about their thyroid disease. But often we see patients who had Graves' disease that was treated, years and years ago that was stable, and then they come see us with these changes in their eyes that have been many, many years. So it's not so cut and dry, but the majority of patients kind of present around the same time. And what does it do to the tissues? Well, it commonly affects the muscles that move the eye. They move the eye side to side and up and down, and also the soft tissues that surround the eye. So within the eye socket behind your eye, you have the muscles that move the eye, the nerve that sends the information from your eye to your brain, and then you have a lot of fat that just kind of is around and behind the eyeball, and in some cases that fat will expand. Now, when those tissues expand, they're sitting in a very rigid eye socket, a socket that is made out of bone that does not expand. So when you have tissues that expand behind your eye, there's really nowhere for your eye to go except move forward. So those tissues expand, and sometimes those tissues can also scar. And when that happens, they don't work as well. So if there's fibrosis or scarring of the eye muscles, they don't move your eye like they used to, and you can get double vision, and your eyes may not look completely aligned. So women, most common, are more likely to have thyroid eye disease. As I mentioned, about 50% of patients with Graves' disease end up having some eye manifestation. Most patients who have thyroid eye disease have some history of hyperthyroidism, but like I said, some may have hypo or normal thyroid. And then they often have elevated antibodies that are directed to one of the receptors in the thyroid gland, the TSH receptor. So when you come to your appointment and we ask you, have you had your blood work checked, have you had antibodies checked, we're looking to see if those have been checked and if they're elevated. So what happens with thyroid eye disease? I know some of you probably feel like this is a condition you've been living with for a long time. It's not something that gets worse and that goes away. And what happens is that there's an active phase of the disease. So once things start, we call it disease activity. Really, it's a progressive phase. So that's when there's ongoing inflammation. So things may be changing at that point. The amount that your eyes are bulging may change. The swelling or redness of your eyelids may change. You may notice that your eyes are more open than before. Those things are actively undergoing inflammation, and they may be changing. So that's why we monitor patients every 6 weeks or so, however your physician thinks is necessary, and we look for those changes as the inflammation is ongoing. For most patients, that lasts about 1.5 years to 2 years, while there's that active kind of changing. And then patients generally achieve a state of stability. And what that means is at that point, there's generally no longer any inflammation, but if your eyes have bulged out, and if your eyes are crossed, if they're not moving as well as they were because of scarring, even though the inflammation dies down, those changes don't necessarily reverse. And that would be the point where if you needed surgery, we would intervene. We don't like to intervene as things are changing because we want to make sure, where we reset your eyes, if we're doing eye muscle surgeries, where you're going to stay. In some rare cases, we might need to operate more quickly, for example, patients who are losing vision. But in most cases, we wait until you've reached a point of stability until surgery happens. So what happens to the eyes in thyroid eye disease? And for those of you who have thyroid eye disease, you already know because this has happened to you and you've gone through it. But a lot of this is for patients who have brought guests with them to help understand what happens. So patients develop eyelid retraction. So that's where the eyelids are open wider than they normally are, and it gives patients that characteristic stare. So if people wonder, why are you staring at me? You're not staring, your eyelids are just happen to be open wider. They get proptosis, which is where the eyes move forward. And that can often make the retraction worse because as the eyes are moving forward, the eyelids are opening wider. So, one can certainly affect the other. When your eyes are open wider and the tissues are scarred, sometimes you can't close your eyes completely, and that causes a lot of discomfort because your eyes dry out, and if you sleep with your eyes open, you wake up and they're goopy and matted and red and irritated. You may have swelling of the eyelids, redness of the eyelids, and also swelling of the skin covering of your eye, and that's called chemosis, and that also adds to the irritation and discomfort. Because the tissues in the eye socket have expanded, the blood circulation in your eye socket, the blood that normally leaves the eye socket, there's congestion. It's not able to exit through the veins because of all the tissues that are blocking the drainage of blood through, out of the eye socket. And you can see here the eye is red, but really it's the vessels that are on the surface of the eye that are big and dilated because they're congested. And then you can have a deviation of the eye, so what we call strabismus, where the eyes are misaligned, and that's because, usually because the muscles are bigger and often they're scarred and they're not working as well. So this will give you double vision. So we always ask patients if you've had a CT scan, and if you haven't, often we order it. And in many ways we order it if we're planning surgery, so we know what your bone looks like and where we can get bone from. But it also helps us know the anatomy and what type of disease you have. So I'm just going to show you a normal CT scan here. These are the muscles that move the eye. This is the eye and the nerve that connects the eye to the brain. This is a cut taken this way, so a horizontal cut. I've drawn a line here, which is how we can tell if the eyes are proptotic or they're bulging. We look to see how much of the eye is behind this line and how much is in front of it. So on the right here, we have a scan of a patient who has thyroid eye disease. You can see the size of the muscles that move the eye. They're 4 or 5 times the size of a normal patient. You can see here where the nerve that connects to the eye to the brain, as it exits the eye socket, there's a lot of crowding here from the muscles. And if the muscles get too big, sometimes they can press on the nerve and cause a reduction or loss of vision, and that's somewhat of an emergency where we would intervene and want to do surgery before you reach the stable phase. And then here you can see that line that we've drawn, how the entire eye is beyond that line, demonstrating the fact that there is bulging of the eye. So those are the changes that we look for. And as I mentioned, we also look at the bone to see where we can remove the bone for surgery. And there will be a surgical talk later, so I'm going to kind of skip over that. What do all these changes mean to you? Well, they mean that your eyes feel pretty crummy. So you may have dryness, and that's because your eyes are open wider. They don't close all the way. They may be red and swollen from that dryness and also from the ongoing inflammation. You may experience, a lot of people say, I have a headache in my eye. It's like a dull ache in my eye. And that's from the congestion, from all the tissues behind the eye being expanded in the eye socket. And it's very common for patients to say, I just have this ache, this headache. You may have double vision if your eye muscles aren't working as they normally do. And then reduced vision, which is what we are always on high alert for. If patients have reduced vision because their optic nerve is being compressed, or sometimes you can get reduction in vision just because the surface of your eye is so exposed from not being able to close it. You may be at risk for developing, a ulcer or infection. So I just wanted to put this slide in here to demonstrate how things may change from active to stable disease. So this is a patient who has active disease. So there's ongoing inflammation. The lids are red, they're swollen. The eye is also very red. And here, this patient was treated with steroids. You can see on the right, the eyelid retraction didn't go away. The patient still has bulging of the eyes, but the inflammation has subsided. And once a patient reaches a stable phase, at that point, we would consider doing corrective, reconstructive surgery to kind of bring them back to their pre-disease state. So what makes thyroid eye disease worse? We say this every time we see a patient. Smoking, smoking, smoking. Whether it's you smoking or being exposed to smoke, that's the one thing we know that gives you an increased risk of your eye disease getting worse and response to treatment being poor. Thyroid dysfunction, we always want to make sure that if your thyroid is not under control, that it gets under control, and you work with your endocrinologist or a thyroid surgeon to get that under control. And then we do know that radioactive iodine can make eye disease worse. We do, if patients are undergoing radioactive iodine, we often treat with steroids to prevent that. We often don't recommend patients who have moderate or severe eye disease to get the radioactive iodine because of this. So in some patients it may be appropriate, and others it might not, but if you're considering having it done, definitely make sure you see an eye doctor so they can look to see what stage your eye disease is at. And then what makes it better? So, stopping smoking and eliminating your smoke exposure and making sure your thyroid function is stable. So I just have a few slides about our thyroid center. This is an old slide, so there's more people been added to it, but we have a multidisciplinary thyroid eye disease center where we manage patients with the ophthalmologist, so not just our oculoplastics surgery team, but also the strabismus surgeons that take care of the eye muscles, the orthoptists that may give you prisms for the double vision, with endocrinologists who manage your thyroid, surgeons who may take out the thyroid if that's what's indicated, with the doctors that give radioactive iodine. So we have a whole team of people that manage your care here in a coordinated way. Our goal is to take what used to happen, and sometimes does happen in a lot of places, where you as the patient are shuttling from one person to another, and everyone's trying to understand what the last person has planned for you, to a system where you are at the center and we are all coordinating your care. So monthly we have what is called a multidisciplinary thyroid eye disease clinic, where we get together, actually here at the Kellogg Eye Center, and talk about you guys, talk about patients that we see, and come up with a multidisciplinary way of managing patients. We create a management plan, and hopefully we are able to provide better care for our patients by having a coordinated approach. So that's a little bit about what we do and what thyroid eye disease is.